Dr. David Goldfarb, Professor of Medicine and Physiology and Director of the Kidney Stone Program at New York University in New York. And I'm going to give you an update on kidney stones. We have a short period of time, so I'll tell you some of the things that we have been thinking about recently. Here's my disclosure. It's important that you know that my past medical history includes calcium oxalate stones. Of course, kidney stones are becoming more prevalent, and these are the United States data, but there are data from the rest of the world that suggests that the same thing is happening. Kidney stones are becoming more prevalent in all populations, young people, old people, men, women, all races are involved, and the reason for these changes are not completely clear. Most of these stones, of course, are calcium oxalate. This is a compilation of all of the stones that were analyzed at the Mayo Clinic in one calendar year in 2010. And of course, most of the stones are calcium oxalate. Apatite, calcium phosphate stones, uric acid stones are part of this epidemic as well, very likely related to increasing overweight, diabetes, metabolic syndrome, which leads to a lower urine pH, which precipitates uric acid. The new concept of the exposome is something that I spoke about at the National Institutes of Health in 2015. The exposome, if you add OME to the end of something, you have a collection, like the genome is really where that began. So the exposome is a measure of all the exposures of an individual. And this begins before birth, and it includes environmental and occupational sources. And the study of this is called exposomics. And you can read about this at the Centers for Disease Control website. There's really nothing new about measuring these sorts of things, what people are exposed to from the point of view of their food, their diet, their activities, but the new abilities to have large databases and have all of this data collected is what's new. So the idea here is that all of our exposures are filtered by unique characteristics. And that middle box, you could also call that the genome. Those are our unique characteristics. So some people smoke, and that's an exposure. And some people get lung cancer, probably because of some genomic issue, and they get lung cancer. Other people smoke and nothing happens to them. And that's probably because of some genomic issues. So the same thing is certainly true for kidney stones, and that's something that I've written about recently. The medical management of kidney stones guidelines, I was one of the nephrologists on the panel here, and this is available at the American Urologic Association website. And some of the things that could be thought of as being related to exposures would be looking at the 24-hour urine collection. And we did recommend that patients have metabolic testing. One of the best reasons to do a 24-hour urine collection would be to find a high urine oxalate. Anything greater than 75 milligrams per day would suggest primary hyperoxaluria, and those are patients that really need to be identified, diagnosed, and then treated with ultimate risk of renal failure, something that they're at risk for, and then potentially needing a liver transplant if they develop renal failure. But we talked about the 24-hour urine collection in this article, which took a more skeptical point of view that came out in the Journal of Urology in 2016. And here we looked at the questions of whether 24-hour urine collections were really necessary. I certainly know that many of you in the audience don't have access to 24-hour urine collections. And that's certainly true even in New York, where there are patients in this crazy country who don't have insurance and therefore may not be able to have or pay for a 24-hour urine collection. So we think quite a lot about whether this is an important test and whether it actually inhibits the appropriate treatment of kidney stones in some instances. So of course, we could review the pros and the cons of doing 24-hour urine collections. It gives us good data. It tells us whether patients are taking their medications or following their diet. Patients very often want to know, why do I have kidney stones? There have been some advances in making this a more convenient test than in the past. And we'd like to believe that the 24-hour urine chemistries are something that will correlate with the outcome. Will you get more kidney stones? But of course, there's some complexity interpretation. We think that some people are inhibited by looking at urine chemistries and find it complicated. Of course, the data demonstrating that the surrogate supersaturation correlates with the outcome is not perfect. There are certainly patients who don't find this convenient and don't want to do it. And as I said, there's a cost to this. So here's one case that puts these ideas together. The exposomics and the genetics and the ability to do 24-hour urine collections. So here's a 16-year-old had her first kidney stone in New York City. And I saw her when she was 23 years old. When her urologist called me and said, she has a low citrate. I can't make her citrate go up. I've been giving her citrate. But at the time she saw me, she was already in moderate renal failure with a creatinine of 3.5. Her urine oxalate was 130 milligrams per day. A normal value is up to about 40 to 45 milligrams per day. And so it was clear to me that it wasn't her citrate that was the issue, it was her oxalate. And so on the one hand, I thought she has a genetic disease. That is certainly an issue. But when I took a medical history, I found that her occupation was a mail carrier. And I found this quite interesting because this really meant to me that she was out all day long carrying the mail without access to fluids and without access to adequate bathroom facilities. And so her occupational exposure had certainly contributed to her recurrent kidney stones, her nephrocalcinosis, leading to her renal failure as well. So this was sort of a combination of all of these issues. We had previously written, this was really my beginning of thinking about occupational kidney stones, about a driver who was taking his boss on long drives on a regular basis and was not allowed to urinate. I can't explain to you why that's true. When he came to us, he already had a poorly contractile bladder, and he had very significant asymptomatic kidney stones. This was really the beginning of an interest in the exposomic idea that there were people with occupational kidney stones. And we wrote this review in 2014 about taxi cab drivers having inadequate access to bathrooms. Certainly in New York, there are repeated articles about cab drivers complaining about poor bathroom facilities at the airports and the like. This is just one example of occupational kidney stones. Here's a study that Amy Krambeck, a urologist at the Mayo Clinic, did. She did a survey of people that worked in the OR versus people who did not work in the OR. And you can see that the OR staff had a significantly higher rate of having kidney stones. They had more kidney stones. They were more likely to report lower fluid intake. And this was certainly true where the physicians who worked in an OR had twice as many kidney stones. So the hazard ratio for working in the operating room was 1.4. This is another occupational kidney stone, part of the exposomics. Obviously, there are genetics to this as well. Another topic that we've talked about recently is whether or not Oxalobacter formigenes is important. And here's some new data that I'll show you. This was the beginning of some studies that we did in 2012. Here, Oxalobacter is an organism that eats oxalate. If you're colonized, if it's in your intestine, it metabolizes the oxalate. So if you have spinach for lunch, the amount of oxalate that you absorb from that spinach may depend on whether or not you have Oxalobacter living in your intestine. If it's there, it will degrade some of the oxalate that you've ingested and reduce urinary oxalate. So it could be protective for kidney stones. We wanted to see whether or not antibiotics were important in changing the microbiome. And we did this study where we showed that in patients who had Oxalobacter at baseline, who were then treated with antibiotics in blue, for Helicobacter infections. These were patients who had been identified because of gastric ulcers, of peptic ulcer disease, and GI bleeding. They received antibiotics versus a group of patients who had had an endoscopy but did not have Helicobacter. That's the control group who did not receive antibiotics. And you can see that the antibiotics for the treatment of H. pylori led to a significant reduction in colonization with Oxalobacter, so that at 1 month, from 100% to 31% now, and at 6 months, this was a persistent effect. Only 16.7% of patients were still colonized. In the control group, there was relatively good preservation, so that if they started with 100%, 83% after a 6-month period still had their Oxalobacter. So this suggested that antibiotics could be a risk factor. And so our new data, and we presented this at the American Urologic Association last year. Most of this work was done by Greg Tazian, a pediatric urologist at the University of Pennsylvania. This was done with the Health Improvement Network database. This is a giant British database. And you can see in blue that the odds ratio for having kidney stone following a course of antibiotics was significantly increased. And this number in red reduced over a period of time, so that 1 to 5 years, the risk had almost gone back to 1. So this was the first data demonstrating that antibiotics may be a risk factor for kidney stones, possibly by eliminating Oxalobacter colonization, but Oxalobacter may be resistant to some of these antibiotics, so that's not necessarily the only effect of antibiotics on the microbiome. You can see that treatment for H. pylori was associated with an increased risk of kidney stones afterwards as well. So this is a potential explanation for increasing prevalence of kidney stones. Antibiotics, of course, have become more prevalent, very frequently prescribed inappropriately, and we need greater antibiotic stewardship in order to ensure that people's microbiome is not affected inappropriately. So let's just talk about prevention of calcium kidney stones. And here's the prescription that I write for many of my patients. You just have to talk to them about water, and you have to explain to them that this is a medication. It's got a dose. It's very effective. It's safe. It's cheap. It's legal. You see on the right, one of my patients made this picture for me. She's got a metered dose inducer of urine output that she takes to work. She's got one bottle for the morning shift and the other for the afternoon shift. I could talk to patients about their fluid intake for a long period of time. You have to really make this an important part of the therapy. It's not enough to say drink a lot. You have to really give it a dose. 3 liters is generally what I recommend. Here's the February 2018 American Urologic Association news, where I talk about what to drink. And the answer for the short answer is almost anything. Really, anything counts. We like to promote juices because they have citrate, which helps prevent kidney stones. The only downside there is the calories. We want people to avoid the calories and sodas, of course, but clear sodas like 7-Up, Sprite, Mountain Dew do have a little bit of citrate and are not bad. Some teas have a lot of oxalate, so we limit people to 1 per day. And it's important that people know that coffee and alcohol have been consistently associated with protection from kidney stones. Una cerveza fría is always a good idea. So if we want to do nonspecific prevention of calcium stones, we want to increase the urine volume. That's been supported by a randomized trial. Emphasis on output, and we've talked before at SLAN. I talked about the fact that urban heat islands, hot areas are associated with greater risks of kidney stones. So we want people to think more about their output than simply their input. We'd like them to drink all day long and before sleeping, and coffee and beer are protective. So what about low urine volume? What about those exposomic issues of patients with occupational kidney stones? And so here are some examples. What I've emphasized is that you cannot increase your fluid intake because you're a surgeon going to the operating room or you're playing baseball, or you're a teacher before class, then part of the idea would be that taking potassium citrate before these exposures to times of heat or times of exercise is probably a good idea. And so I don't have the data to support this as an important therapy, but it makes sense. If you're going to have a low urine volume, let's have some citrate in your urine at that time. The dietary therapy of kidney stones hasn't changed recently. These are the data of Gary Curhan demonstrating that people's risk of kidney stones decreased as their dietary calcium intake increased. This was first shown in the New England Journal in 1993. Then Gary published similar data in the Annals of Internal Medicine in women. Consistently, people who had more calcium had fewer kidney stones. Presumably, this is because calcium binds oxalate, reduces its absorption. And serving as an oxalate binder, it's going to reduce the amount of oxalate in the urine. That was followed up by these data from Borghi. This is the only randomized trial of a diet that showed prevention of kidney stones. People were put on, these were men in Italy treated with two diets, one low calcium, that was the traditional diet for a long time for high urine calcium, compared to a diet that had normal calcium, that was 1,000 to 1,200 milligrams per day. They reduced protein intake and salt intake. Both groups were given advice about lowering their oxalate intake as well. And you can see that the patients on a low calcium diet after 5 years had about twice as many kidney stones as the group on the higher calcium, low protein, low salt diet. So these are old data, but still this is the diet that I give my patients. So calcium restriction is not appropriate. It was never proven to reduce stone recurrence, and it presumably is associated with bone demineralization as well. You may know that patients with high urine calcium and kidney stones tend to have low bone density. So we encourage our patients to take 3 or 4 servings of calcium per day. That's 250 to 300 milligrams of calcium per serving to total about 1,000 milligrams of calcium per day. For pharmacologic therapy, thiazides are appropriate. I prefer the longer-acting drugs, chlorthalidone and indapamide, instead of hydrochlorothiazide. Lower salt intake to make this effect greater and limit potassium losses, and supplement with potassium citrate. Don't use triamterene to prevent potassium losses because it's a poorly soluble drug that produces kidney stones. Remember that thiazides are as effective as any other class for treatment of hypertension as well, and very effective for systolic hypertension in the elderly. By lowering urine calcium, they consistently are associated with increases in bone density and fewer fractures, and even potassium citrate by itself, because its potential base and neutralizes acid, increases bone density. So the treatment of kidney stones with thiazides and potassium citrate is associated with increase in bone density, lowering of blood pressure, increases in life expectancy as well. So if you wanted to treat patients empirically, if you simply wanted to do this without a 24-hour urine collection, because many of us, you and I, are in situations where we cannot get the 24-hour urine collections done, I don't think it's difficult to know how to treat patients empirically. Prescribe 3 liters of fluid per day, spend some time talking to people about what that means. The Borghi diet, dairy is good, increased calcium intake, less sodium, oxalate, and protein. Potassium citrate can be given empirically. My dose would be 20 milliequivalents twice a day, assuming that it's available. But that's a dose that can be associated with prevention of kidney stones, even in patients who don't have a low urine citrate. And then giving thiazides like chlorthalidone or indapamide can be given empirically, because even in patients who don't have a high urine calcium, thiazides will lower supersaturation and prevent kidney stones. I want to thank my hosts for inviting me for this opportunity to talk with you, and please email me if you have questions. Thanks.